Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Sanchit Singh, gastroenterologist at Max Hospital, Kaushambi, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hello and namaste. I am Dr. Sanchit Singh. I'm a consultant gastroenterologist associated with Max Vaishali. I've been in practice for more than 14 years in the field of medicine, and I've been a gastroenterologist for somewhere around 7 or 8 years. My primarily workplace is Max Vaishali, where I've been practicing since last 4.5 years now. Thank you so much. Let's proceed.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
Okay. A very simple question, yet with different answers for interpretation. But just to make it simple, IBS is basically a short form for irritable bowel syndrome. Irritable bowel, as the word suggests, irritable bowel means the bowel is irritated by something. That means the bowel is hyperreactive at times or hyporeactive at times. So basically, the one thing which is common with all different definitions of irritable bowel syndrome is that there is some amount of pain. So usually irritable bowel syndrome is a clinical condition in which there is pain associated with some sort of change in the frequency or the consistency of stool. In simple terms, if I have to explain it, it is basically a disorder in which the patient feels pain before or after defecation, and there is some change in the type of stool that he is passing. That is, patient can have diarrhea, patient can have constipation, patient can have symptoms in between both diarrhea and constipation, and there is usually some sort of slight discomfort in abdomen that the patient experiences before there is change in the frequency and the consistency of stool. So in simple terms, if I have to explain, it is a sort of pain abdomen that the patient experiences associated with either loose stools or constipation. I have to explain it in the simplest forms. This is what an irritable bowel syndrome is. But at the same time, there is no underlying structural or pathophysiological entity associated with irritable bowel syndrome in the bowel, that the bowel is structurally normal. There is no disease in the bowel per se. The bowel is anatomically, there is no constriction in the bowel. There is no pathophysiology which is running in the bowel. There is no disease per se in the bowel, but there is more of a disease of motility. That is, patient can have varying amount of motility, that is loose stools or constipation. But the bowel is consistent, but consistently the bowel has no structural abnormality which explains the symptoms of the patient.
How does modern lifestyle food habits, stress, and sleep contribute to IBS?
Okay, so as I just said, irritable bowel syndrome is a disease with variable pathophysiology. There are multiple theories regarding the reason why irritable bowel syndrome develops. First and foremost, it develops in younger patients. It does not develop above 50 years. It is usually seen in younger patients, middle-aged patients, and it is seen in these patients who have no structural abnormality. The bowel is functionally normal, but the patients still have these symptoms of pain, still have these symptoms of loose stools or constipation. So why does it occur? So the different theories that are present for explaining irritable bowel syndrome, one of the most important is visceral hypersensitivity, anxiety, dysbiosis. So whenever there is a stressor is there, so the bowel tends to get dysregulated. The motility tends to be different in these patients who are having more stress in their lifestyle. That is why a patient who can have disturbed sleep, patient can have high stress levels at work, patient can have a stressful job per se. So these personality changes, these personality disorders, these lifestyle related problems contributes towards development of irritable bowel syndrome. Food habits have a major role in the pathophysiology of irritable bowel syndrome. Patients who tend to take less amount of fiber, patients who have increased outside food, that in India we have patients taking more of processed foods, can have increased chances of developing irritable bowel syndrome because there will be changes in the motility of the gut which contributes towards irritable bowel syndrome. Sleep is a very, very important factor as far as IBS is concerned, because a good sleep is very important for keeping yourself calm, keeping the endorphins and keeping your good hormones in place, which ultimately a lack of sleep will dysregulate the entire mechanism which connects your brain to your gut. As a result, you can have increased chances of developing irritable bowel syndrome. As we'll talk further during this particular interaction, we will get to know how does basically the changes in the microbiota, changes in the gut and the brain axis can basically contribute towards the various symptoms of irritable bowel syndrome. So modern lifestyle, food habit, stress, sleep, all are a contributory factor towards developing irritable bowel syndrome. Constipation can develop in patients taking less amount of fiber, whereas stressors, lack of sleep can contribute towards irritable bowel syndrome of the diarrhea predominant variety. Also, these patients in India, it is more of an unclassified and mixed type of irritable bowel syndrome, which is more prevalent, and that is really contributed mainly by the lifestyle disorders and the food that we are having in our country.
What are the top 3 red flags that make you suspect IBS in a patient?
Now, IBS is one of the most diagnoses that we make in our daily OPD practice. Multiple studies have shown its prevalence varying from 6 to 30 to 40% in Indian populations as well. There are multiple studies which tells us about the prevalence of this disease, but it tends to be still undiagnosed because a lot of the patients just do not report to the doctors itself, because they just let it off that probably these symptoms are somewhere related to the type of food they're having, or it is related to the lifestyle that they're having. So they don't really report it to the doctors most often. So whenever a patient comes to us in the OPD, one of the most predominant sine qua non for irritable bowel syndrome diagnosis is pain abdomen. So pain abdomen is the one factor which is very important for diagnosis of irritable bowel syndrome. It can be a dull aching sort of pain, or it can be a colicky pain which comes and goes. So one of the red flag is pain. Second red flag is a chronic sort of diarrhea. And the patient tells that whenever he feels stressed, he's passing stool 3 or 4 times. Whenever he's going on a visit, on a trip, he's passing stool 2 to 3 times. Or there can be a mixed pattern in which patient says sometimes there is diarrhea, that is followed by constipation, that the patient is unable to pass stools at times. Or it can be that the patient just keeps feeling some amount of pain and the patient is having too much of constipation, is not able to pass stool. But the one factor that is important and differentiates it from idiopathic constipation is that the patient has some sort of pain abdomen and some sort of stressor which is associated with the onset of these symptoms. That is when we start suspecting IBS in these patients who have been chronically seeing a lot of doctors, who keep on complaining of some amount of pain abdomen. They've been thoroughly investigated and find nothing. Endoscopies, colonoscopies, everything has been done. But these patients have no problem in their gut. It is just the symptoms just won't go. So one of the most important red flags is that patient keeps on having pain. They can have variable amount of diarrhea, can have variable amount of constipation, and the gut just doesn't seem right to them. And a lot of Stressors are usually associated with these symptoms. Most of these patients that we see tend to have some sort of stressor in their life which contributes to their gut dysregulation.
How do you differentiate IBS from lactose intolerance, celiac disease, or functional dyspepsia?
Okay. Now, very interesting question and a very, very important question. As I have already mentioned, irritable bowel syndrome is a syndromic diagnosis. Patients can have pain abdomen, patient can have constipation, patient can have diarrhea, and usually these patients tend to be less than 50 years of age. Can I make a diagnosis just based on history? Any patient comes to me, pain abdomen, diarrhea, irritable bowel syndrome, take these drugs, go away. No, it doesn't happen like that. Important to understand, irritable bowel syndrome can coexist with a lot of conditions which need to be ruled out before we make and label the patient as IBS. If a patient of lactose intolerance is labeled as IBS, is not given the right dietary advice, he will keep having the symptoms, he will keep taking dairy, he will keep having those symptoms again and again, and the IBS drugs won't help him. So there are multiple things which we need to consider. One of the important thing is lactose intolerance. Second is celiac disease. Third, which is very common, is functional dyspepsia. Lactose intolerance is a simple diagnosis. Patient takes dairy, patient takes milk, the lactose gets broken down, it produces a lot of gas. Typical symptom, typical triggering factor, lactose containing products. Milk, symptoms, patient feel gassy, patient farts a lot, typical diagnosis of lactose intolerance. So it is a food triggered diagnosis. It is different from IBS because of IBS, there is no specific trigger usually. Patient is unable to define the trigger. There can be multiple triggers as well. But usually milk is not the only trigger. They can be precipitated by a lot of factors, stress being one. Celiac disease, now very, very important differential diagnosis. The reason why celiac goes undiagnosed in India is because everybody starts labeling it as IBS. Not every diarrhea is IBS, as I previously said. Not every constipation is IBS. You need to make sure that the patient is not suffering from these conditions which can be treated and which need a specific treatment and diagnosis. Celiac disease is a disease in which the patients is basically gluten sensitive enteropathy. So when the patient takes gluten, which is basically predominantly found in wheat in our country, it attacks the enterocytes. The protein. Because of the protein, there are protein breaks down. It affects the immunity in the body, and as a result, the immune cells attack the small bowel cells. As a result, the small bowel gets destroyed slowly and slowly. So there is destruction of the small bowel cells, because of which patient becomes malabsorbent towards multiple nutrients. And pathophysiologically, we see on endoscopy, we see blunting of the villi in the small intestine when we do an endoscopy. It has specific endoscopic findings. It is because of the gluten that is found in wheat and the related families of wheat. It is a specific diagnosis, needs total removal of gluten and gluten related products from the diet, and it treats the disease completely. So it's a disease which is triggered by gluten. You avoid the gluten completely, a gluten-free diet, the symptoms are completely ameliorated. The malabsorption that happens because of celiac disease is completely ameliorated. This needs to be diagnosed based upon specific antibody test and endoscopy. Functional dyspepsia is very interesting differential diagnosis because functional dyspepsia is something which will coexist with irritable bowel syndrome in a majority of patients. In Indian patients especially, there will be some component of functional dyspepsia which is usually seen in these patients. But functional dyspepsia tends to have more of upper abdominal discomfort in the form of postprandial discomfort, postprandial vomiting, postprandial bloating. These are the main predominant symptoms. Bloating is a more predominant symptom. But these patients tend to have less amount of pain, which is predominant symptom in irritable bowel syndrome. And the diarrhea and constipation can sometimes also coexist with functional dyspepsia. But functional dyspepsia, the bloating and the abdominal discomfort in the upper abdomen is more predominant, and the pain is usually less predominant. Pain is one thing which you associate more with irritable bowel syndrome, and the stress factor, as far as the stressor is concerned, the stressor factor is more related to irritable bowel syndrome than functional dyspepsia per se. So that is how you need to differentiate between clinical condition based upon the symptomatology, based upon the triggering factor, and based upon how the disease basically presents in relation to stress. That is how you can basically differentiate between these clinical conditions.
Are there any warning signs where a physician should immediately refer to a gastroenterologist?
Absolutely, yes. There are multiple warning signs which you have to be very, very well aware of. In fact, the main important thing that you need to be aware of in IBS is when to refer. So, any patient who's presenting with symptomatic diagnosis of IBS after 50 years, patient having a symptom, new onset diarrhea or new onset constipation after 50 years, something I would not label it as IBS straight away, because then I need to investigate. It is a disease which takes place more commonly in young patients and not in elderly patients. In elderly patients, we need to rule out other causes. We need to rule out a celiac, we need to rule out a microscopic colitis, we need to rule out any lymphomas, we need to rule out carcinoma colon, we need to rule out small bowel lymphoma. So any onset after 50 years, any onset with a recent change in the type of stool that the patient is passing. The patient was having normal stool, sometimes diarrhea, sometimes constipation. Now there is an increased constipation. That is when you need to refer. Patient was having some amount of diarrhea. Again, suddenly there is sudden worsening of diarrhea. That is why when you need to refer. Blood in stool. Irritable bowel syndrome, as I just said, it is not a structural abnormality in the bowel. If the patient is having any blood in stool, which is mixed with blood especially, they can have hemorrhoids associated with constipation at times. But if there is stool which is mixed with blood, increased frequency of stool with passage of blood and mucus, then you need to refer the patient. Blood is something that you cannot associate with IBS. It has to be investigated thoroughly by a gastroenterologist with an endoscopy or a colonoscopy, depending upon the symptoms. Otherwise, you do not label it as IBS if the patient is having blood in stool. Next important diagnosis, next important red flag, any weight loss, any loss of appetite. Weight loss, appetite, anorexia, absolutely no for you to make a diagnosis of IBS. IBS seldom will cause any loss of appetite or weight loss. IBS is a benign diagnosis. It is a syndromic diagnosis. It should not cause any sort of loss of appetite or weight loss. It is not a malabsorptive disorder. There is no malabsorption. All vitamins and minerals are adequately absorbed in the bowel. It is a disorder only of the motility, and the motility will not contribute towards any sort of malabsorption. So whenever there is onset after 50 years of age, elderly patient, recent change of bowel habit, blood in stool, any anorexia or weight loss, absolute referral to a gastroenterologist should be done by a physician who's treating for an IBS patient.
What's your opinion on the role of rifaximin in IBSD? Where does it fit best?
Rifaximin is an extremely good molecule for treatment of irritable bowel syndrome. Nowadays, it is being used as a first line for patients with irritable bowel syndrome. It is a basically gut-specific antibiotic, which does not get absorbed. It's basically a gut sterilizer. So the role of rifaximin in IBSD is usually first line nowadays, especially in the diarrhea variant, as it has been said. So rifaximin is usually considered first line for IBSD. It is a neuromodulator, so it modulates the amount of pain that the patient is feeling. It relieves the excess bacteria if there is any. So it can also treat small intestinal bacterial overgrowth. It usually will be more used for patients of irritable bowel syndrome diarrhea variant. However, patients of IBS-C who produce methane more, it is studies, it has been found that methanobrevib, the bacteria which can increase the amount of methane in the large bowel, or these patients can also get benefit from rifaximin. So rifaximin in IBSD is almost first line nowadays. It should be used in all patients. Patients do respond well.
What's the role of diet? Do you recommend low FODMAP, fiber modification, or any particular dietary pattern?
Absolutely, yes. I think diet is extremely important in irritable bowel syndrome. Diet is the one factor which is actually modifiable and is something which the patient will adhere to well if informed properly. And this is the one which makes a difference in the management of irritable bowel syndrome. Patients of IBS-D tends to have increased bowel frequency. So these patients are better advised to take lesser amount of insoluble fibers like bran and all those stuff. These can still take psyllium husk that is commonly available in India. That is a type of fiber which can reduce the motility in these patients. And a very important aspect is FODMAP, fermentable oligosaccharides, disaccharides, monols and polyols. These are the food items which have a lot of fermentation, which ultimately leads to increased bloating, increased amount of production of gases because of the fermentation. There will be increased motility because of the fermentation, because of certain products, and ultimately these will alter the frequency of the bowel in these patients of irritable bowel syndrome. So usually it is advised for these patients to take a low FODMAP diet. If I give you an example, patients of IBS would be advised to not to take things like ginger because these are high FODMAP. Now it is usually seen in India. Low FODMAP diet in northern population is an extremely difficult thing to follow because we use a lot of condiments in our diet. Ginger is a very commonly used condiment in our northern Indian population dietary pattern. So low FODMAP diet is very difficult to follow in Indian setups. In Western setups, it is still easier to follow. In South India, it's slightly better to follow, but in northern Indian population, low FODMAP diet is very difficult to follow. Although yes, patients of IBS-D or IBS-M or IBS-C are advised to take a low FODMAP diet, whatever they can follow. But even with low FODMAP diet, patients can have certain triggers like pineapple, usually a low FODMAP, but certain patients it can increase the symptoms of bloating and functional dyspepsia. So it has to be a tailored sort of management in these patients. They should be advised a low FODMAP diet wherever they can follow and identify the triggers for diarrhea in these patients of IBS-D especially. And then they can basically get a good tailored sort of regimen as which food can trigger their irritable bowel syndrome symptoms. And patients of IBS-C are advised to take as much of fiber as possible so that the constipation gets relieved with the dietary modification. For example, psyllium is usually advised in fibers in the form of bananas, apples, and all those simple things which are basically readily available in India are advised to these patients so that the amount of fiber is increased and it does not produce too much of gases as well, and the patient is able to pass stool at a much better frequency without any therapeutic intake, without any medications. Patient is able to pass stool just based on diet. So that is the role of diet. Diet has very, very important role as far as IBS is concerned.
What are some practical ways physicians can build patient trust in IBS treatment?
Trust development is basically dependent upon how well the patient responds to your treatment. If the patient does not respond to your treatment, the patient will not get the trust. Patient will not visit you again. So there are multiple tools nowadays for management of IBS symptom monitoring. I think the patient should be given short-term tasks. Patient should be given short-term resolution of their symptoms. For example, if a patient of IBS-D comes to your clinic, you have to give him certain advices about your dietary fiber, about the modalities of treatment which are available. There should be a close follow-up as to whether the patient respond to your treatment or not and how much is the improvement in symptoms. So close follow-up would be one thing which is important. If the patient does not improve, then there should be gradual step up to other therapies, because in IBS there are multiple therapies available. So the therapies have to be switched if the patient is not getting relieved of the symptoms, so that the patient develops a good trust that the physician is empathizing about the symptoms and is able to respond to those symptoms which are not responding well. So there has to be close association between how does the patient respond and the physician, so that treatment is tailored. The patient develops some sort of trust in the physician as to the doctor understands what sort of symptoms the patient is experiencing and is able to tailor the treatment. So that develops a sort of trust between the physician and the patient for the management of IBS, and the patient will also be more confident in getting treatment from that particular physician for a long term, because IBS is not a disease of 1 or 2 days. It is a long term lifestyle related disorder. sticks with the patient. So unless until a good trust develops between the physician and the patient, it will be difficult for you to follow that patient for a long time, and it will be difficult for you to stick with that patient.
What do you wish every consulting physician understood about IBS?
I wish everybody is able to understand that it is a diagnosis of exclusion in certain patients. It is not a diagnosis that you make in elderly patients. It is a disease of the young that I had previously mentioned. It is a syndromic diagnosis which needs certain exclusions that I had previously said. And whenever there is any red flag as far as IBS is concerned, patients should be referred to a gastroenterologist so that a particular diagnosis is not missed. That is the foremost and the most important thing, is that when you not suspect an IBS, whenever there is bleeding, there is elderly patients, all those things, whenever there is a red flag, you need to refer the patient to a gastroenterologist for a thorough evaluation and to exclude other pathophysiologies which are associated with IBS, rather than ruling in IBS in every patient who is suffering from a diarrhea or constipation. It should be, especially in elderly patients, it should be made as a diagnosis of exclusion only. And younger patients also, if there is any red flag sign, the referral should be as prompt as possible.
What's your gut-friendly morning habit?
Gut-friendly morning habit, we would be taking just a tablespoon of honey with some lime, which is very good. Or we can take something like a kanji, something like a fermented rice, overnight fermented rice, which are good for the gut. Eggs in the morning would be very gut friendly. I should avoid tea and coffee right in the morning before taking anything in breakfast, because that really tends to affect the acidic pH of the stomach. So just a bit of lime and honey and some sort of probiotic drink in the morning would be excellent for the gut. Thank you so much. Thank you so much for listening, and namaste.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.